Yes, good afternoon, and thank you for the opportunity to present today at APACC. I'm Professor Wai-Kay Seto from the University of Hong Kong, and today I'll be talking about the prevention and monitoring strategies for liver cancer in patients with chronic hepatitis B. So these are my disclosures. If you look at the epidemiology of liver cancer, it is the seventh most common cancer worldwide. But notably is that it is ranked second in terms of cancer deaths, both worldwide and also in East Asia. You can compare that of liver cancer with other common cancers in our locality. And especially you try comparing it with that of colorectal cancer. In East Asia, colorectal cancer is actually more common than that of liver cancer. But because liver cancer has a case fatality rate that is more than twice of that of colorectal cancer, and that is why in terms of cancer deaths, liver cancer is actually ranked second. And the reason behind this is the stage of diagnosis. If we can achieve an early diagnosis, that is diagnosing liver cancer when it is less than 2 cm in size, you can see that the 5-year survival is actually very high. But once it progresses and evades to adjacent structures, you get a much lower survival rate. When we talk about risk factors for hepatitis B related liver cancer, first we have to understand the lifetime risk is quite high, 10 to 25%. And this varying in incidence is because there are so many risk factors that are related to hepatitis B related liver cancer. And we are very well aware of those that are well established: age, male gender, Asian or African ancestry, or even the viral factors like HPV DNA levels or the HPV genotype. However, today I will also discuss about some emerging risk factors which have been published in recent years. If we are talking about HPV DNA levels, this is the most conventional key risk factor. Studies done really some time ago in Taiwan have shown that if you have a higher HPV DNA level, the chances of you having HCC actually increases. And it's not just a high level. Even those with a moderate level, what we define as less than 2,000 IU per ml, you still have a slightly increased chance of HCC, whether you are in the untreated or you're in the on-treatment population. The key thing is that these HPV DNA levels, they are really more important in the era when majority of patients do not have any treatment. Nowadays, when we actually have treatment that is actually widespread and commonly seen, HPV DNA is probably not the most important risk factor. We need to look at other risk factors. For example, is there any difference in the use of the hepatitis B related antiviral drugs? There has been a lot of debate on this. Some studies have shown that tenofovir is better than entecavir, while meta-analysis seems to show that their efficacy is rather similar. You ask me, my personal opinion is that probably tenofovir or TDF is slightly more oncoprotective, but only to a very, very small margin. And eventually, there's really no need to compare efficacy between the two drugs. As long as the patient is on one drug and is taking a drug, that is the most important. So the established risk factors that I mentioned, they would definitely increase the chances of HCC. But nowadays, we are in the era in which hepatitis B virus is suppressed by nucleoside analog therapy. And that is why we need to look at other risk factors, the emerging risk factors, which I would say, which are also important to oncogenesis. And when we want to talk about risk factors, there used to be many different prediction models, as shown here, which we can predict whether a patient would get HCC or not. These are predominantly based on untreated patients. And when you use a drug like TDF or actually also entecavir, it really defeats the purpose of using a prediction model. As long as the patient is on a drug, then it is better than using a prediction model. In fact, probably we need new prediction models in this area. And there are also different limitations of prediction models. There's a lot of bias. For example, there can be surveillance bias in which you are actually looking at a patient cohort that was studied in which there is a higher chance of the outcome of liver cancer. That is probably the cohort that has been studied actually had a high proportion of cirrhotic patients. Or there could be what we call a sentiment bias, in which that if we are looking at historical cohorts, they have fewer on-treatment patients as we see than nowadays, then this can also affect the generalizability of these risk prediction models. And of course, there are also confounding factors. One important confounding factor is diabetes. This was not studied much in the natural history studies of HCC many years ago. But if you look at more recent studies, we can see here the chances of a hepatitis C patient if he has concomitant diabetes, the chances of him getting a liver cancer actually increases by twice. And if there are other metabolic factors, the chances also would increase. In fact, if the glucose or the glycemic control actually worsens just by 1 millimole per liter, the odds ratio for HCC would also increase. So diabetes is actually one very important risk factor. Another very important metabolic risk factor is obesity that also has not been thoroughly documented in Asian studies. But in this study, it already shows that if you are obese, the chances of you getting HCC in the hepatitis B carrier also increases by twice. If you look at other drugs, not only the drugs that are taken to protect against hepatitis B, but also drugs that are not related to hepatitis B, they also have an oncoprotective effect against HBV-related HCC. This study from Taiwan actually shows the oncoprotective effect of statins, and this effect actually increases with the increase in the cumulative dose. And it's not only statins. Recently, also from Taiwan, there's been very nice data on the oncoprotective effect of aspirin. In this study, which has been adjusted for all these confounding risk factors, then actually the chances of you getting HCC if you're hepatitis B carrier and taking aspirin, it actually reduces by almost 30%. And it's not just only drugs. There are also other environmental factors which can contribute to HCC development. Alpha toxin is very well known. And in this study here, it shows that if you have an increased environmental exposure to alpha toxin, resulting in higher levels, the cancer can actually occur earlier. And while alpha toxin is a bit more well known in terms of the environmental risk factors, there are still other risk factors. But probably I would not say risk factors, or maybe protective factors against HCC. So this study conducted in Japan, in which they included 90,000 patients with viral hepatitis, although majority were hepatitis C and not hepatitis B. They had a very detailed 28-day diary record. It shows that if you are taking fish that contains N3 polyunsaturated fatty acids, your chances of HCC will reduce by 35%. But of course, you have to be taking it, or maybe this kind of sushi 4 times per day for breakfast, lunch, and dinner. And that is actually not easy for many of the non-Japanese. Not only fish, but also coffee. Coffee also has an oncoprotective effect. I must admit that we don't have pure data in those who are hepatitis B carriers, but in this large registry, it shows that if you are taking coffee of at least 2 cups per day, it can also reduce HCC by 38%. And so when we are talking about the risk factors for HCC, yes, there are established risk factors, but there are also emerging risk factors. So actually, the whole process of risk factor control is actually quite complicated. Even if you are taking a drug for your hepatitis B, this does not omit the risk of you getting liver cancer. And one thing about liver cancer is that unlike those of other cancers in which we have very nice data showing the contribution of risk factor, screening, and treatment in the prevention of related cancer deaths, for liver cancer, we simply do not have such data. So when we have no data, both risk factor control and other methods like screening are important to prevent cancer deaths. And there's actually good, I would say, not perfect data, but good data on the advantage of liver cancer surveillance, which is ultrasound every 6 months in the at-risk population. This meta-analysis shows that you can actually improve survival with an odds ratio of 1.9. And being a meta-analysis, there are definitely limitations. Non-randomized, short duration of follow-up, and of course, lead time bias. But that is already the best data that we have. And because of this availability of this data, we now have this recommendation. If you are in the at-risk population with hepatitis B, male 40 years or above, female 50 years or above, liver cirrhosis, or a family history of HCC, then we actually recommend you to go for a 6-month ultrasound surveillance of which can actually help detect an early cancer, and this can actually help in reducing the chances of cancer death. What can we do in the present? I must say that besides for having risk factor control, besides cancer surveillance or a very prompt diagnostic, which are step 4, 5, and 6, let us start at first step 1. You cannot do anything if the patient himself does not know whether he or she has hepatitis B or not. And there's been a lot of message from the WHO saying that there are still large populations of patients who are unaware that they have viral hepatitis. So if your population is endemic for hepatitis B, please recommend them to go for screening. And if they are positive, please refer them to the appropriate care. These are all very important steps before we can even talk about risk factor control and cancer surveillance and so on. So while I've talked about today about the importance of preventive and monitoring strategies for hepatitis B related HCC, the most important step is to identify the patient first. And with that, I'd like to end my lecture of today, and I would welcome any questions in this area. Thank you so much.